Can you see it?
Yes, we can see it. Thank you.
Okay, thank you very much for this introduction. I will certainly not address the issue of the elimination of hepatitis B in Switzerland. I will try to provide you a more global appraisal of the situation. And I will address not everything, not all points. We don't have the time. It's outside of the scope to check everything. I will try to give you some ideas about diagnosing the diagnosed, the addressing the migrant health, why treatment is not enough, and I will talk more in detail about some issues related to the challenges to reduce incidence. In other words, the hurdles to universal vaccination. Diagnosis is a major source of headache, unfortunately, for hepatitis B. It's not only hepatitis C, as you may understand. There are several models and studies which have addressed the low rate of diagnosis across the world. I'm just quoting the recent appraisal made by the Lancet Commission, which was published in the Lancet last year. And you can see easily from the WHO regions diagnosis rate how some rates are extremely poor. The African region is estimated to have only 0.3% of people with hepatitis B being diagnosed. And we are just barely higher than 10% in Europe, but many other areas are really concerned by this lack of diagnosis. There are certainly several reasons for that, and it's difficult to identify all of them and provide a ranking of what is the most important to the least important. But I would like to point out one difficulty, that is the awareness even among specialists. If you look at the liver societies across the world, and I have an incomplete list, and I also include the WHO, by the way, they in general address the recommendations regarding treatment of patients with hepatitis B. They've been extremely ineffective in addressing issues regarding screening and screening strategies. For example, you see Latin America, Indian, even Chinese societies of hepatology has no specific guidance regarding screening of hepatitis B. And this also applies to Asian Pacific, which is actually is probably one of the most important across the world in terms of also of basin being covered in terms of prevalence of hepatitis B. Some indications are provided by the American Society and even the Gastroenterology and Hepatology Association for Sub-Saharan Africa. They very recently published, but they are just addressing risk-based strategies, which other words means that there is no mention whatsoever in any of these society guidelines the possibility of running a lifetime, once in a lifetime screening strategy. This is quite bad also because if you look at the distribution of the prevalence of hepatitis B, 60% of those infected are living in low or lower in middle income countries according to the lending capacity as defined by the World Bank. 60% is a huge number. And you see here especially the red and orange countries, which include, by the way, also China. China is a lower middle income country still now. And the reflection of this situation is in the cascade of care. You see here that according to a Polaris Observatory, published data show that the cascade of care is extremely poor in lower middle and especially low income countries. You see here the rate of diagnosis is extremely low, not to mention those who have been treated. We cannot certainly discuss all the aspects and the details of the hurdles to diagnose hepatitis B in these areas. There is certainly a lack of political will. Clearly, hepatitis B is not high in the priorities of local governments. There is a general lack of awareness and advocacy, awareness especially among the political structure. There is a lack of infrastructure, and clearly when infrastructure is lagging behind, governments certainly are not going to invest prioritizing an hepatitis B in their own policy. Quality assays is very poor sometimes, and many assays used locally have not reached WHO pre-qualification, And also we have to mention that when you use the brand diagnostics in low to middle income countries, their cost can be much higher than the cost of generic medicines. And this is quite discouraging to see that foundations like, for example, FIND, which is Foundation of Innovative Diagnostics, has not a specific program so far on hepatitis B. This may actually come in the near future, but so far is not really the case. So people coming from low to middle income countries are very often representing the bulk of migrants to richer countries, of course. As you know, ECDC has provided over the years a snapshot of the percentage of foreign-born populations across the European Union, and the proportion born, especially HBV endemic countries. See here that if you consider overall the European Union, 10% of migrants are actually represented the overall population, and 40% of them are coming from highly endemic countries, which means at least 2% of the general population. That means that migrants represent the bulk of hepatitis B infected persons in most rich countries, especially Europe, and also Switzerland, according to this data provided by the Federal Office of Public Health by Christian Schetti. He presented this data some years ago. Situation has not really changed. 82% of hepatitis B being declared by practitioners to the Federal Office of Public Health have a foreign origin. This situation has been rendered acute and is certainly getting worse in the future years due to the persisting conflicts in very hot areas of the globe, especially the Middle East, in some areas in sub-Saharan Africa, especially Chad and Nigeria. As you all know, unfortunately, Mali also is contributing a lot. And this chart represents essentially where all these migrants go. Switzerland is certainly affected by this, and we cannot close our eyes and ignore this fact. Not only because of these poor migrants are very often infected, but also because they may have been excluded from a vaccination program. So there is one more reasons to test these people. It is actually to make sure that they are protected, they are immunized against hepatitis B. This data is not very recent, but is still valid today, unfortunately. I would like also to underline what are river-related health issues among asylum seekers, even though they are very often young and probably in general good health, otherwise they probably not migrate. Unfortunately, they are at risk, a very high risk sometimes of hepatitis A outbreaks, sexual abuse, and sexually transmitted infections, including, of course, in this case, hepatitis B, and social marginalization, which may lead to substance abuse and all the consequences you may understand, especially if they are not vaccinated against hepatitis B. There are several very serious barriers to health screening in migrants. First of all, we don't really have a tradition of migrant medicine. There is a lack of staff training and support, professionalism, poor management of these patients very often. They are erratic consultation. Funding schemes have not been adapted in many countries. The communication is clearly very difficult sometimes because of the language barriers or religious and cultural barriers, which implies also on our side some cultural inadequacy. It's also maybe some insufficient patient involvement in delivery and testing, and the user-friendly settings are certainly contributing to very poor management of these migrants. And this is the reason why the European Association for the Study of the Liver last year published a policy statement, which is freely available on our website regarding liver disease and migrant health, which addresses not only problems related to hepatitis B, but all liver disorders related to migration. I will not deal too long on linkage to care, because in our country, certainly not a problem. All general practitioners can prescribe freely medicines for treating hepatitis B. I'll mention very briefly just one wonderful study which was run by Mark Thurs and Modlem 1 in Senegal and also in Gambia, which was funded by the European Commission, the Prolifica study, and not only showing one single slide to show you what can be the barriers to screening and to linkage to care in these settings, very poor settings. If you look at the plan of this slide on the right-hand side, the reasons for non-participation in screening programs are extremely diverse, but some of these reasons will certainly strike you. They struck me, like, for example, husband refusal, or not trusting medical research council. I mean, feeling ill, but was too busy. These people have certainly other priorities, like the one of making money for making ends meet at the end of the month. So certainly hepatitis B is not the most important priority in most people in the world, unlike probably in Switzerland. Treatment works, and this has been very nicely shown by the several studies. There is even a wealth of meta-analysis showing that the incidence of decompensated cirrhosis, HCC, or HBV-related death compared to placebo is decreased by about 3/4. It's very nicely shown. Certainly not reduced to zero. It certainly is not impacting in a significant way, at least in the first few years from treatment initiation, the incidence of hepatocellular carcinoma has been shown very nicely by Giorgio Papatheodorou. This is multi-center study from Europe showing how even under treatment, people keep developing cancer. And this is shown also by local data. I think all centers who are dealing with transplant, liver transplant, have a possibility to share this same view. You see, for example, that the number of transplant due to hepatitis B complications has not really gone down over the years, despite availability of a very powerful drug, especially in recent years. What has really changed is the profile of these patients who reach the transplant. For example, we see less and less decompensated liver disorders, but we see more and more hepatocellular carcinoma. So you may ask why this is the case, why despite the fact we do have a very good treatments, why we don't see this disappearing completely? Well, the reasons are several. Probably the most important one is that we cannot even really eradicate the virus from the liver. And we cannot reach in a substantial proportion of patients the so-called functional cure, which is the surface antigen loss and seroconversion, because there is a persistence of a mini chromosome inside the hepatocyte nuclei and some integrated DNA, which may, in the very end, cause cancer. And this minor chromosome is quite resistant to treatment. The half-life has been shown to be extremely long, especially in those patients which constitute the bulk of our hepatitis B chronic patients today, those who are e antigen negative. There are several drugs being evaluated now. The approaches are quite diverse, and some of these, especially capsid assembly inhibitors, look very promising in increasing the suppression of viral replication and possibly also inhibiting the recycling of pre-genomic RNA into a newly formed mini chromosome. But clearly we need more data in the long term to see whether they are really effective in reducing the incidence of cancer. Let me spend a few words about vaccination, because it's a very dear topic to me. As I think everybody understands and accepts the fact that the global HBV vaccinations campaign is indeed a success story of medicine, the first vaccine in the history of medicine which is effective in preventing a cancer. And according to this WHO modelization, vaccination has been estimated to avert 310 million new cases of chronic HBV between 1990 and 2010. But is everybody really profiting from this success story? Well, the answer you know very well is not at all. And especially if you go back again to lower, middle, and low income countries, look at the birth dose vaccine rate. It's extremely poor. And the only way to avoid the transmission of the virus from the infected mothers, and the infected mothers are several still in these countries, to the progeny, is to immunize children at birth. You cannot wait more than 72 hours. Clearly, infant vaccination is clearly not enough. And for this reason, at least 20 countries, according to the Polaris Observatory models, are not on track to reach the 2030 and 2020 targets for HBV prevalence among the 5-year-old children, which is what we use as a benchmark to measure the effectiveness of immunoprophylaxis at birth. So there are foundations, again, who are dealing with this problem. Vaccination is being provided free of charge by Gavi via some funding schemes, which imply, of course, the co-funding of governments, local governments. And the vaccination against hepatitis B is extremely cheap now. It's slightly above 20 cents of a dollar, so it's actually at the threshold for co-funding rules for Gavi. But Gavi can do very little if the infrastructure is not there. In fact, Gavi has decided last year to stop paying for vaccination for hepatitis B. I mean, stop buying the vaccines, doses for birth dose campaign, and focus on infrastructure. clearly buying vaccine is clearly not enough. We have to overcome barriers. We have to overcome barriers to logistic provisions. So, I mean, it's very difficult to deal with the settings where there are not only infrastructural problems, but also cultural barriers. Let me give an example. I mean, what can we do? In some settings, only men can study and become medical doctors. And this is clearly a barrier for many pregnant women, especially premarital women counseling. They have limited access to maternal care because of gender bias. This is quite a disaster. And also, I would like to add the fact that in these countries, very poor countries, vaccination may not be perceived as a priority because at least 50% of these deliveries are not attended by skilled medical or paramedical personnel. They're not there, and the consequences are quite sad because these mothers may actually transmit the virus, understand, but also many of them will die of maternal hemorrhage, sepsis soon after birth. And just to give you an example, I mean, by the time I will be done with my talk, 20 women will have died or undergone lifetime complications related to delivery in sub-Saharan Africa, just to mention. So the other point, which is actually not a problem for poor countries, but is a problem with rich countries, is vaccine hesitancy. Everybody remembers these stories about the measles vaccine hesitancy. The movie Vaxxed by Andrew Wakefield and the question why parents refuse to vaccinate. There is one single book I would like to mention and to recommend you strongly to read is this investigative journalist called Brian Deere, who actually exposed the Andrew Wakefield's machinations against the measles vaccine. But these concepts apply, unfortunately, also to hepatitis B. Everybody remembers the story about multiple sclerosis in France. The vaccine hesitancy is actually a disease, quote unquote, of rich countries. And this has been very nicely shown also recently with the COVID crisis. Was this survey carried out in France, 50% of French people do not want or they perceive like unsafe any vaccination. It's an emergent issue.
Negro, I ask you to maybe shorten your speech a little bit because
I will. I'm almost done. Yes, I'm almost done. Sorry about this. The vaccine hesitancy is reported among 20–30% of parents, is affected by many factors, as you see here, to the point that the WHO has declared vaccine hesitancy one of the 10 threats to global health in 2019. It's clearly a difficult decision of parents because you must, of course, deal with many personal issues. Sometimes the failure to understand that the freedom of choice clashes with collective responsibility, the so-called role of anticipated regret, and also sometimes parents have some difficulties to accept that their child may grow as a possible risk-taking teenager, like, for example, in the high-risk sex and so on. So this is a real problem, this conundrum for our countries, rich countries. I think vaccine hesitancy has to be dealt with quickly because there is a lack of confidence in science. We can, of course, improve the rigor in science, improve access to data for general practitioners, avoid that pediatricians, for example, lose confidence in science and the vaccine especially. We must improve pharmacovigilance, clearly, ask the collaboration of media. I'm very happy that you represent Intermedia here today. But also on our side to teach communication skills, to explain, for example, risk to benefit ratio and emotional intelligence, address cognitive biases, and maybe we invest more what is called in public engagement of science and technology, which should be actually just replace this paternalizing view we have been having until now of dealing with the patients, so so-called public understanding of science. With that, I really want to conclude my talk, and I'm ready to take any questions.
Thank you very much, Mr.